It's really important to screen and to understand how screening works with folks with a gambling disorder. Largely and still in this country, it's been a don't ask, don't tell policy. Most people, come in, as I mentioned earlier in the research, folks with a gambling disorder, 50% of those in one large study were getting help for something else. None of them, not one, not one, was getting any help specifically for their gambling disorder. People aren't trained in it. So we have to train people on how to open the conversation. We talk about screening, and there are 2-question screens, 3-question screens, a few question screens. And in the research, they work really well. If you're in a mental health or a substance use facility, they will find 20 to 50% of the folks you're working with who have some level of gambling problem. In real clinical practice, when we use those same screens, we get 1 to 4%. So the screens don't work the same in clinical practice as they do in research. In research, mostly the paradigm is I tell the research participants, this will be confidential. I'm not going to tell your counselor. I'm not going to tell your probation officer. I'm not going to send you to another treatment program. I'm not going to ask that you give up something else in your life that brings you some pleasure. In clinical settings, our clients understand that there will be consequences if they talk about and answer yes to items that may indicate they have another problem, and they're not ready to do that. Or they haven't even thought of gambling as a problem, or they don't even understand what you're talking about when you say gambling. If I ask a client, when did you last gamble or do you gamble? They're very likely to say no. If I follow that up and say, when did you buy your last lottery ticket? Did you buy some tickets when Mega Millions was just up a few days ago? Oh, yeah. At work, we combined our money and we bought some tickets, and I bought a couple on my way to your office. People don't categorize certain forms of gambling as gambling, like lottery play or bingo. The only forms of gambling that consistently get identified are casino games, and things like sports betting or horse race gambling. So if you say, I'm going to ask you some questions about gambling, and then you ask, have you ever lied about your gambling? I'll say, no. They don't mean those lottery tickets I just don't happen to tell my spouse about, and dismiss that. So yes, we need to learn how to screen, put the screening items in your intake. Just don't expect to be done with it. You're not going to get a lot of people answering yes to those questions at intake. We can ask more subtle questions like, how do you spend your recreational money? Do you watch movies? Do you go bicycle riding? Do you go out dancing? Do you go to the casino? Do you buy a few lottery tickets? And ask less threatening questions than the screening questions, which are often, defined by diagnostic criteria that, identifies the top tip of the iceberg, but not those folks who may have beginning to experience a few problems with gambling. So we need to look at the impact of gambling in our clients' lives in more in ways that don't initiate a lot of resistance or defensiveness. Um, what do you do for fun? How do you spend your weekends now that you're not consuming a lot of substances and spending money on alcohol or drugs? What are you doing with that money? Are you saving it? Are you paying you back child support? Are you buying a few more lottery tickets? So we need to train folks already working in medicine and behavioral health how to look for potential problems that may suggest that we ask some questions about gambling. Are you taking your medication? Are there times when you don't take your medication? Is that when you're at the casino and you don't wanna leave your machine because it's due to pay off any minute now? So lots of issues like that. It requires significant training to understand how to effectively begin the conversation about the impact of gambling in a person's life. Throwing in some screening questions is easy, but that's not the whole job. It's not one and done. We screen to open the door a crack, to let people know we talk about this in this setting. And then we ask again when we're re-updating treatment plans, or again when you come in for your annual physical, just like they ask about abuse or depression or substance use. And we need to learn how to ask about gambling activity participation rather than just trying to identify somebody with another label of disordered gambling. If somebody does respond to a screening item or more subtle items that they may have a gambling problem, then, if I'm a primary care provider, I'm not going to do treatment. I'm not going to stop and say, oh, we need to treat this. So I need to know what the resources are. I give the person some feedback. You scored 1 or 2 on this gambling screen. That puts you in the range of at risk. And would it be okay, ask permission if I gave you some information? And if somebody screens says no on all the items in some practices that we're piloting in medical settings, we still give the person some info. Thank you for asking these questions about your gambling activities. You scored in the low risk group, but here's some information just in case you know anybody who might have a problem or might be able to benefit from this information. So we have levels of feedback we can provide based on the level of response that a client may come in with. And we structure it in a way so somebody who's a medical provider, a doc, a nurse practitioner, or somebody who's working in mental health and isn't a gambling expert can feel assured that they have the resources, they have the concrete feedback they can give this client and the concrete referral sources so they can take it, offer the next level. It's important to realize that this individual has choice. Even if they answer yes to every one of the screening items, and your head is screaming to you, oh my goodness, this person has a real problem. It's still their choice what to do with that. It's our job to offer some information. Would it be okay? And we ask permission. We don't just shove it at them. Here, take this. Would it be okay? Would you be interested in some more information for learning more? Not about your gambling problem, but learning more how gambling might impact whatever the person is there for. Your depression, your anxiety, your high blood pressure, your ulcers, whatever it might be, your well being. And we do some training to help the providers understand what their role is. And it's not a scary role, it's not as scary as they think. And we go over the materials with them so they'll understand what they're offering their clients. And then they can let it go. You don't have to make somebody. We've learned over the years that we can't make people do things. We can only create an environment in which they are more willing to think about changing some behaviors that may be less than helpful to them in achieving their goals of well-being and health in their lives. So the what next is just feedback. It's the SBIRT model: screening, brief intervention, including some personal feedback, and then offering of referral if the person is willing to take that offering and letting them know the door is open and you can help them connect with whatever resources they might think will be helpful in their life, looking at the role and the impact of gambling on their well-being. So that's the process.